Hi, everybody, and I hope you're enjoying this workshop. We're going to talk about thermal ablation for GBMs now, and I'm very proud to introduce Dr. John Ragged, who's going to be sharing the session with me. He's the director of neurosurgery at Nicklaus Children's Hospital in Miami. He's also the president of the American Society of Pediatric Neurosurgery, and he's also the PI of a feasibility safety study of benign centrally located intracranial tumors in pediatric and young adults. So even though he has a tremendous amount of experience with benign pediatric tumors, it's really important because we really don't have a lot of experience with thermal ablation in GBMs right now. The history was that back in the late 2000s, we tried to do thermal ablation through open craniectomy defects, and then subsequently in 2010 and up to 2014, we tried to do it through the intact skull. And there were some technical challenges, some clinical challenges, which have really precluded the advancement of thermal ablation for GBMs. So I thought perhaps, Dr. Raghib, you would kind of share with us your experience of doing thermal ablation for some of the benign tumors, and then hear your thoughts on how and if we can expand that to the treatment of GBMs.
Yeah, thanks, Susan. Thank you for the foundation for the opportunity. It's exciting to be part of this. I'm going to learn more, I'm sure, than I share, but I appreciate the opportunity. I think each time we try to push the envelope, we learn. And the examples you gave about the efforts to treat malignant gliomas created an opportunity for us to learn how to structure a trial first with young adults for benign lesions. We chose benign lesions to avoid specifically markedly vascular lesions that might put the child or subject at risk for hemorrhage. I think that our success in the few patients we've treated so far is directly related to the lessons learned from that initial work. And we have been able to treat both hamartomas and low-grade lesions successfully without hemorrhage or without significant complication, but at very reduced volumes, less than a centimeter and a half cubic centimeter in volume, and managing the challenges of cavitation and other sorts of technical issues. So, in summary, I think we've learned about using high energies and high temperatures to try to create ablation in malignant lesions that are prone to hemorrhage. We went to the opposite end of the spectrum and have avoided that. And eventually we're going to work our way back toward where the clinical need takes us, which will inevitably involve treating malignant lesions that are more vascular. But I think that's going to be an incremental process as we gain experience with thermal ablation in first intermediate grade lesions and then ultimately in more aggressive ones.
Right. Well, your experience is invaluable, and I think you make a nice segue into treating benign tumors up to GBMs, and there are some in-between grade tumors that maybe are not that vascular, have non-enhancing components, or decreased perfusion. So do you think that we're ready to try to do thermal ablation in those lower grade adult tumors and earlier stage tumors?
Yeah, it's a really good question, and what I would say is that it's less the grade of the lesion than it is its vascularity. And there are pilocytic astrocytomas, WHO grade 1 tumors that are extremely vascular, and there are malignant or intermediate grade tumors that are relatively hypovascular. And I suspect that it's what we'll learn is how far we can push that envelope with respect to heat and time, temperature and time, in the presence of an abnormal endothelium. So in a very vascular low-grade astrocytoma, it's yet to be seen if we can deliver in temperature and time of significance to create ablation per se. I must say that I'm concerned how far we can push that, and would suggest that if a clinical trial were to be developed, it would be one in which we would incrementally start with the grade 2 lesions and then transition slowly to those that are more vascular. Examples might be a grade 2 lesion like an anaplastic ependymoma or an anaplastic astrocytoma without evidence of hemorrhage before you progress to a GBM with evidence of hemorrhage, or an ependymoma with evidence of hemorrhage, or other malignant lesions of that nature. So I think I think it's going to be an incremental process. I think we need to finish our work with benign astrocytomas first before we move on to the more aggressive lesions.
Yeah, and that's a great point. It also brings up the promise of how FUS can fit into the armamentarium in different ways, along with other combinatorial therapies. Do you think that we could do microvascular disruption to decrease the amount of enhancement and then do the focused ultrasound? Or how do you feel about that?
I've enjoyed the few sessions I got to listen to today between surgery and patients in the office, because I learn a lot every time I get to listen to one of these Focused Ultrasound Foundation webinars. I think we are learning how to rethink the delivery of energy using sound and how to measure that response. And that response will be not simply a matter of temperature and time and the simple equation of ablation, but more the disruption of cellular function, blood supply, either of which may achieve the same goal, which is to create tumor control. At least hopefully will create tumor control. So I think we're going to learn about how to add adjuncts to the delivery of energy to the brain, measure that response, and then tailor it to the pathology. I'm looking forward to being part of the next phase of the benign astrocytoma trial, which will be WHO 1 and 2 lesions. But I think we're going to measure response in different ways aside from just temperature and time.
Right, great. And I think one other small point I'd like to just bring up and get your thoughts is about inciting an immune response, right? Can we use thermal ablation a little bit to incite an immune response, mechanical ablation, but for this conversation now, the future role of affecting the cancer immunity cycle will be interesting. Any thoughts?
I mean, that's another fascinating strategy, again, with the potential to use lower energies and reduce the risk of hemorrhage or cavitation, but yet may get the desired response, which is tumor control. I mean, there are other mechanisms which I see on the agenda for today are radiosensitization, or as an adjunct to radiation therapy, its ability to just deliver medications. The opportunities are going to be tremendous, and I think mere thermal ablation is just the tip of the iceberg. It's the easiest thing for us to quantify and measure at this point because it's sort of the most obvious, but probably will not be the sole tool within the focused ultrasound toolbox for the treatment, particularly of malignant lesions in the future. I mean, you can think of it, it's easy to imagine exceptions, right? If there's a small residual in an area that couldn't be reached prior to the onset of treatment, you might go back and treat that small residual enhancing nodule in the perioperative period. You could think of examples where thermal ablation with focused ultrasound energy might be a good adjunct, but to treat a large variegated lesion like most GBMs with enough energy to create thermal ablation, I think is not likely. There will be other ways to use ultrasound energy, like immunomodulation, like drug delivery, like radiosensitization.
Well, thank you for your perspective, and thank you for your experience, because your experience with the pediatric population and ablation is going to be invaluable for us moving forward. So thank you, everyone. We're going to take a short technical break and move on.
My pleasure. Thanks for the opportunity.